in today's episode, we're going to talk about, do you age slower with HRT? I'm Dr. Valorie.
And I'm Dr. Maki. So let's just sort of dive into this question. This one sort of comes up in some ways, but you and I were actually driving in the truck the other day, and I asked you a question like, why would a woman actually want to take HRT? Just a broad-based question, sort of an obvious one, but as we started talking about it, I just was curious what your answer was, just in a general sense, and I thought it'd be a good episode, a good topic for us to do on the episode.
Well, it was interesting because we've both been doing HRT, hormone replacement therapy, with women for perimenopause and menopause for, 20 years now?
Yeah, long time.
And women come into us and tell us about their symptoms, and we, if they seem like a good candidate or this is going to work out, we're, do some hormone replacement. But you never really broke it down into like, why? Why would you do hormone replacement therapy?
Yeah, it's really easy as a practitioner. You get sort of, you get into the routine of what you're doing and taking care of people. And, you and I have been doing some other things. We just did published a newsletter, and we've been doing some other content things. And
yes, we just did a newsletter. I'm working on some social media. That's why I said, I don't know how many times I've said perimenopause and menopause in like the last 3 weeks. I must have said it like 5,000 times.
Yeah.
If you hear me saying it over and over, it's just because it's become a repetitive pattern.
Sure. So we've been working on some things. We've been thinking about, obviously, more topics like this. And I just asked you that question. So we thought we would, again, like I said, turn it into this episode. But you're totally right. It's not something that you sort of think about those things, but you don't break it down into like, what's the real reason why, why a woman would want to choose to do HRT.
Yeah, because, we have people that come in with symptoms, or menopausal symptoms, hot flashes, night sweats, low libido, vaginal dryness, joint pain, sleep issues, you name it, hair, skin, and nails. You have those. And then you're looking at the long-term aspects of it with bone density and heart disease and dementia and brain health and weight loss. It was interesting when you asked, like, why would someone want to take HRT? Why take HRT?
Well, I think you just said something there that was interesting. Like, thinking about it from the patient side, all those symptoms is what their motivation is, right? That's what is going to bring them into the door initially, because they're sort of miserable, right? The hot flashes, the night sweats, they can't sleep. All those symptoms are going to be, in the short term, what they want to get rid of. Now, what you and I are talking about, is there additional reason or benefit as to, once those things are taken care of, then what? Then where are you left, right? So I just thought we could have a little discussion about that and sort of tease that a little bit, so that way, actually, you and I are clear about it. I know you and I are clear about it, right? But just sort of articulating that in public, I think, is worthwhile. So from a practitioner thought process, and then how does that translate? How does that benefit the patient, both in the short term and in the long term? Which
is why I thought this, concern that we were going to talk about, does HRT, slow down aging? Is that the idea behind it? Is, we always talk about the new, well, maybe it's not new. Now it's longevity treatment, or because anti-aging was a big thing for me when I started in 2000, 2004 was, we're working on anti-aging. It's anti-aging, HRT and anti-aging. Now what is it? Longevity medicine, or went from functional medicine to longevity medicine. There's always a new term on the blog, but it was about, the HRT. And I know once women come in, we work on a lot of their symptoms, they come back and we work back and forth, and they're feeling pretty good. And of course they want to continue feeling pretty good. That's why you don't stop the HRT necessarily. That's a whole new podcast we could talk about, is, can you stop HRT abruptly? Do you need to transition off? And should you even stop HRT? Because
what is, so speaking of that, that's another topic. So what is the, I can think of a couple, what's the oldest patient you have that's on some form of hormones right now?
Oh, definitely in their 70s. I don't think I have any patients yet in their 80s, because I started about 20 years ago. So I actually have a lot of my current patient base still. Granted, that's, things have changed, but I would say we've kind of, I want to say we've grown up together. We've gone through perimenopause and menopause. We've grown up together. That I would say I definitely have patients in their 70s, and they're on HRT, different forms of HRT. But I think one of the biggest things, or did you want to circle back around and tell me how your oldest
Oh, I
patient
know
on
one
HRT?
for sure right off the top of my head because she just turned 80 and she's still doing hormones. Another one I know, there's another one that's 76. And I know there's a few that are in their earlier 70s. So, and then of course, a bunch in the 60s, a bunch in the 50s, a bunch in the 40s. So really you're talking 40, 50, 60, 70, 80 is sort of where you're probably drawing the line a little bit. She's the first one that is actually into her eighth
Not
decade.
necessarily for safety, just more about just taking it,
Yeah,
really.
yeah.
It's not about safety.
More about compliance, like does she really need it? Now, there's a lot of our patients that I can predict that they're gonna absolutely continue to do it, into their 70s and 80s because, as we were talking about, do you age slower with using HRT? And I think that's a kind of a mixed question. Do you technically age slower? What is your definition of aging? Right? You have to define that. Now, you and I are not going to get into all the physiology or the biochemistry of the aging process. Now, like you said, when early 2000s, when we were just getting started, that anti-aging word was everywhere. Now you don't hear it as much. I think you're right. It's sort of evolved a little bit to more health span, longevity, some of that type of stuff. But it's really ultimately the same thing. I mean, it's really the same sort of conversation. How can we live? And you and I sort of live that same, that's the same reason that we sort of do this and live a certain way is because we're trying to live. It's amazing that you and I are in our 50s, right? I mean, where does the time go? I mean, I'm sure everybody watching is like, 1 minute you're a teenager, then you're in your early 20s, you're in your 30s, and then you wake up and you're 50. It's like, where does the time go?
That was the conversation we were having the other day is, there's different research studies out there, and who knows if they're even great because of the patient population or what the age is or what they're taking.
The design of the study.
Yeah, exactly. But we do know, whether you take hormones or you don't take hormones, you're going to live a long life. We're going to live, my parents are in their 70s. My mom's never taken HRT. That's a whole nother subject. She's in her mid 70s. We're going to live a long life.
Yeah.
But
well, now the new generations, the generation after the baby boomers, I think it might be, we're considered Gen X. So millennials or the Gen Zs, their lifespans are getting shorter. So
I hadn't heard about that.
Yeah, I don't know if that's new research or something. So don't quote me on that, but I think that might be part of this transition that we're in. So we go from a lot of longevities to now it's starting to reverse a little bit.
I sure hope not. I hope that's just some weird science or something.
Well, I mean, it's just statistics, so who knows what that means, right? I haven't looked into it enough to know if that's actually true or not. I've just listened to some other, health-related podcasts, and I heard some people talking about some numbers that actually the numbers are the lifespan is actually decreasing, for like the first time in American history, So that's why I think it's relevant to talk about, how do we live a lifestyle, a quality of life, the way we want for as long as we want. Okay.
Well, let me finish what I was saying because I know. I'm sorry.
Okay.
I don't want to interrupt you, but
go ahead.
I don't want to lose my thought process.
Yeah.
I am over 50.
Go ahead.
But it's true. Now that I'm going to be 52 in a couple of weeks, and you'll ask anybody over the age of 50, and I think this is why we want to take the HRT. I got here fast.
Yeah.
I mean, all of a sudden, I can't believe you're right. I'm 52 years old, and you ask anybody over the age of 50, and they'll say, "My gosh, I got here fast. I don't want it to end. I don't want it to be over. Of course, we know we're going to live a long life, but I want to live a really good life. Like I still want to be able to, go hiking and walking and maybe a little jogging. I still want to be able to, have my cognitive. Yeah, I got the readers on. Sure, that's inevitable, but I still want to live healthy and feel good, where I feel like the HRT brings such an aspect to that. So it's not about, I want to live longer. I just want to feel better while I'm living.
Yeah, right. That patient I was talking about, the 80-year-old, and her and I talk on a fairly regular basis, and she's really tired. She's really, really tired. How do you sort of, when you're already 80 and trying to improve your quality of life can be a little challenging, right? How do you do that when you're already in your, eighth decade? I think when you are, where you and I are at right now is how you prepare for when you're in your 70s, 80s, and beyond. waiting until then, I'm not saying that she didn't prepare, not saying that she hasn't done her part. She's 80. She's got her faculties. Her and I have good conversations. She's slowed down and mellowed out a little bit, but she used to be a little bit of a spitfire. But, trying to change how you live and how you feel when you're in your 70s or 80s versus taking those actions early to make sure that you're in a better position then, I think is worth the conversation.
So I guess what we're kind of saying is, between menopause is we want to feel good, right? I want to feel good now. I want to feel like I'm feeling right now for a long time. We want to feel that way. And so like you said, but then also working in a way that you're preparing yourself for when you are in your 70s and 80s so that you still feel good. Maybe, I could slow down a little bit. I could be a little less intense, right?
Well, I think what you're talking about there is, and I'm just using that patient of mine as an example, because she's tired. There's only so much we can do to sort of increase her energy. She sleeps a lot during the day. She's napping mid-morning, mid-afternoon. She's sleeping during the night. I think that's sort of a common progression. I grew up, around my grandmother there's a lot of elderly people that I grew up around, and they're all sort of the same way. All right. So our patient population and other people that seek out doctors like you and I across the country, they have a little bit of a different trajectory. Right? There is a completely different path that a lot of them are taking because they are putting in that work now. They are putting in that effort, whether that's hormones, nutrition, stress management, exercise. They're keeping their bodies, they're maintaining their vitality, for as long as they can. So, and granted, a lot of them are not there yet, but I think the hormones help facilitate maintaining that vitality over those sometimes 25 to, potentially 30 years for some of them.
Yeah, no, exactly. So it's interesting you're saying that because we do have a lot of patients in their 70s and they're out there swimming, they're in a bathing suit, they're eating good, they're exercising, they're walking, they're hiking, which I don't, when I was younger, I didn't have as many people that were, over 70 around me. I just had we have a very small family in general, but they seem a lot different than what I remember when I was little, what 70-year-olds were like.
Sure. Even 60-year-olds, 50s and 60-year-olds were, considered senior citizens. Like right now, you're 50, you're going to be 52 in like, a few days, a couple of weeks. 55 would have been considered a senior citizen. Now, I've talked about this with some of my patients too, and it helps them kind of put in perspective. We have people that are in their 60s and 70s that don't feel like they're senior citizens, right? Even though in our generation, in our lifetime, it would have been, completely different. So I do think that maybe the research and looking at how you would design a study like that, what parameters they're looking at, kind of throw that off to the side. But just looking at our patient population and how well a lot of them have actually aged, how well they're able to maintain their quality of life day by day, year by year, I think that's the conversation that you and I are trying to have right now.
Because you think about there's so many receptors in every single cell in our body has a receptor for estrogen and progesterone, testosterone, DHEA, all the hormones that we're replacing once the body stops making them. Now we're talking about mainly more menopause because the ovaries stop making the progesterone and the estrogen, but you have the other hormones like the adrenal hormones. They'll start to decline a little bit with time.
Sure.
So you're trying to balance that. So I do feel like in terms of we were talking about earlier is, hormones are really great for bone density, but then at the same time, if the hormones help you feel better and you're sleeping better, then I have more energy to want to go for that hike and do that exercise, which is good for my bone density. Right.
So if you think about it, that the hormones in some ways are like PEDs for women because it's helping their performance, which then helps. So meaning that they're active, meaning that it maintains muscle mass, which then, as we've talked about before, and it's all over the internet these days, all the longevity doctors are saying how important it is to maintain muscle. So hormones maintain the muscle maintains the hormones, and it creates a little bit of this kind of cycle that goes around. If you become sedentary, right, and how many people do we know that are sort of sedentary, they don't move at all, they're declined. So, I've heard there's a book called, I think he's from Vegas, actually, Michael Easley. I think he wrote a book called The Crisis of Comfort. And he's talking about how the more comfortable we are, in some ways, the quicker we decline. And I think there's some truth to that, right? So the hormones help facilitate living an active lifestyle, physically pushing your body to a certain point, maintaining the muscles, maintaining metabolic health. That's only going to translate into a better brain, or at least a maintained brain, better bones, better musculature, like I said, and that metabolic health. So the diabetes and the pre-diabetes and even the cancer, those things are not going to catch up with you. Those are going to be pushed down the road potentially by a decade, 20 years, 30 years. Now you're able to maintain a quality of life well into your 60s, 70s, and 80s, and you're not living 30 years with a chronic problem of some sort.
Yeah, exactly. I mean, I had just had a patient earlier today, and she's doing fantastic, and she's just starting to go into menopause in her early 50s. She's just starting to go into menopause. Now, for her, I'm doing a little bit more of a static dosing where she's just doing honestly, a very low dose of HRT. And she feels amazing. She's sleeping. Her hair, skin, and nails look great. She exercises every single day. I mean, she eats great. She already had a really good baseline lifestyle to begin with. This just really kind of helped keep her there, right? Because when you're not sleeping, you're going to want to eat a little more sugar. If you're not, if you're tired and you don't feel good or you're getting hot flashes, you're not going to want to go exercise. So like I was saying, it's a little bit of that chicken and the egg. Now me, myself, I went through menopause at 50. And I've done all sorts of things because I like to try everything because I'm the hormone doc. So I got to experiment a little bit on myself. But right now I'm doing the rhythmic dosing, which is not a low dose of hormones. It's actually a pretty good amount of estradiol that I'm doing. There's different ways you can do the rhythmic dosing, but I'm basically recreating the 28-day cycle like my ovaries would with the estrogen and the progesterone. So right now I think I'm on day 4. I'm on day 4, so I'm just doing an estradiol twice a day, but it's a good amount of hormones. And I mean, I will say I feel a whole lot better than I did when I first went through menopause. Even on the static dosing, honestly, for me, I feel like it's better.
Now, you and I talked about that because so you're going to be 52, so there was about a 3-year period, let's say 49 to now, okay, or a few months ago when you started the rhythmic dosing, so roughly a 2.5 to 3 year period where you weren't really a candidate for the rhythmic dosing quite yet because your period is a little bit more consistent. So what was I sort of know, but I'm just curious, what was the difference between what you were using before static dosing wise versus now? What do you know difference wise?
Well,
as far as how you feel?
We'll say, like was going into menopause about 50, but I was still having a period every once in a while. I was, taking progesterone. I've been taking progesterone for years. I love that for the perimenopause. But then I would go a little longer without a period, like maybe 65 days to 70 days is kind of nice, and then until it wasn't, then I'd have like 2 periods in a month, and I'm familiar with that. Okay, but it's so different, treating all these women for menopause and then having it myself. It's it's a little different to try to. That's why I would talk to you a lot, because I need a little bit of an outside perspective in terms of treatment. And you had actually recommended doing the rhythmic dosing, even though I've done that with other women. I was even just like, should I do that? But I do notice that it's so much better for my brain, because with my menopause, which if you look at my news article, I wrote an article about this, is I really didn't get a lot of hot flashes.
No.
Really, I didn't gain any weight. My hair is still fine. I didn't notice any difference with that. The main thing I noticed was my cognitive. Like I would drop words. I would say a lot. I never say And then I would try to talk in a different way, trying to find different adjectives or reconstruct my sentences because I couldn't find a word. So you try to find one, like instead of saying, purple, I'd say, that lavender color, that would, it was very strange to not be able to.
Because you've always been sharp as a tack. I mean, ever since I've known you, quick. You're just like, you're just like spot on, sharp. I'm not saying that I've noticed any of that. I haven't noticed you using ums and ahs and losing words.
That's very nice of you.
Well, I might notice some other things,
I think
whatever.
More so, especially also with clients, because, when you're talking to a client, there's a little more of a stress factor there where I'm more comfortable with you. It's easier to get the words out.
That's
I can pause a little bit more. But something like in a podcast like this or talking with a client, there's just probably a little more cortisol, a little more stress. So it's harder to get the word.
Yeah,
it's in my brain.
It's a different type of conversation. Yeah, I totally get that.
Yeah, or even like ordering food at a restaurant, because I'm naturally kind of shy, so it would just come out weird. or like at the store. It was just very strange. But I did notice once I started the rhythmic dosing, really, really nice for that cognitive. Now, it took a couple of months. Like I think I'm on month 4 right now. Maybe it's month 5. I'd have to look back at my calendars. But the first month was better. But then I started getting a lot of breast tenderness and just my body trying to understand that the hormones are coming back like they had been. Probably hadn't been that way as my body is, as your hormones are changing, they don't turn off. Your estrogen starts to drop. That progesterone had already dropped. So reintroducing an actual rhythmic dosing of proper hormones for a cycle, my body hadn't seen that for a little bit. So it had a little growing pains or a little bit of time to get used to that. But now I feel like coming up, I think I'm either on month 5 or month 4, I feel like my body has gotten used to it.
And in my experience, now granted, now you know how I feel, a man dealing with women in menopause, it's a little challenging. I'm telling women about their bodies. It's a little bit of a disconnect sometimes. It's, I've learned a lot from you over the years, right? So I've learned a tremendous amount of insight and clinical pearls, and then just listening a lot. So you pick up on things and pattern recognition. There is, even though for a woman, menopause, it's different for every woman, but it's also relatively the same collectively as a group, right? They're just, this person will have this collection of symptoms, and this one, like yours was more on the cognitive side, less on the temperature side, right? Where another woman might have more on the temperature side, less on the cognitive, or all the above. Right. So understanding some of those nuances, but collectively there's some very easy patterns to recognize there. And I feel like as a clinician, I feel like I'm relatively good at noticing or recognizing those patterns. I think as doctors, I think you sort of have to be. That's sort of part of the diagnosing process in general. But the rhythmic dosing, I thought right off the bat, because you were freshly or newly into menopause, I thought that the rhythmic dosing was just sort of an obvious transition for you. Now, the interesting thing is I'm also doing rhythmic dosing testosterone for men, and because you're the woman, so you start the protocol, and then my protocol actually follows your protocol. So your day one is my day one. Mm-hmm. When you start over, when your period starts, whatever day that is.
So I'm getting a period.
Yeah. So what is that average for you? Like how many days from cycle to cycle?
I'm usually almost exactly for the last few months on day 26. I think this day 26 or day 27. I think one time I made it to day 28, but that's actually pretty normal. That was normal for me even when I used to get my periods, is right around day 26 to 28. And now they're even finding out with some more studies is that the average cycle length for a female is like 25 to 26 days. Mm. So, and the interesting thing for me is, which is how it should be when you're doing the rhythmic dosing, is I don't have the heavy periods. They're very easy peasy. I don't know that they're coming. It just starts. But luckily it's not like super heavy. So it's coming at some point because you're getting towards the end of your cycle. But every month I would ask you, what happens if I go over day 28? I know what to do, but I have to ask you because I don't feel like I'm going to get a period. And then all of a sudden it shows up and then it's gone,
Yeah. Well, I think that's actually I'm preaching to the choir to you, but just for everybody listening, I think that's a very positive sign of balance. Mm-hmm. Okay. When the estrogen and progesterone are sort of in the right place, there really isn't supposed to be a lot of PMS. PMS is a sign that things are sort of messed up. Your stress level goes up, metabolic stress, lack of sleep, too much, job stress, family stress, and now your PMS, the 7 to 10 days before your period is going to be that much worse. So the fact that there is very little PMS, I think, is a really good sign. And all the women that I've had, now granted, I would say just like everything, right, 80-20, 80% women do great, and 20%, actually probably more like 5 to 10, are the ones that are going to struggle on the rhythmic dosing. They just, for whatever reason, their bodies just don't, because it is when you look at static dosing, like the actual milligram amount compared to rhythmic dosing, it is no comparison. Okay? And that's why we're talking about it, because in order to achieve some of those results, I think it is really all about the dose that you're using. Mm-hmm. Now, the rhythmic dosing, it's about the dose and how you're using it. Okay, so the hormones rise and fall over the course of a month. That is the part that makes it beneficial, both in the short term and in the long term, but also the part, as we always talk about, the part that makes it safe for a woman to do. Because if you think about it, a woman getting her period in her 60s, on the surface, that seems very strange. Like, why would you do that? That seems dangerous. From a traditional gynecological approach, that doesn't seem right. And all of a sudden, which we've had a lot of patients, they do, their doctors want to send them in for a transvaginal ultrasound. They don't realize that we're intentionally trying to create that situation.
Yeah, and then you have that period to slough off that lining. But, you were talking about a little bit with that rhythmic dosing, kind of circling back to our original question. How do you feel about the rhythmic dosing in terms of aging?
Yeah, right. That's what we're talking about, because I think that and I had another thought about, we're kind of all over the place a little bit, but this is I think an important conversation for women to think about for themselves, what's best for them, right? This is our experience, both personally for you and as clinicians, but that way women can sort of decide which route do they want to go. They want to go static, they want to go rhythmic. What goals, you've always taught me too, that what goal do they want to achieve will sort of determine some of those things. And it's our job to help them facilitate what's the best option for them based on the goals that they want. So you just asked me a question. What was the question you just asked me?
Like a little bit with the aging when you're looking at the HRT. Like, you're right. Everybody is different. I have so many patients that I have on this dose, and rhythmic dosing, different dosings on that. Like, everybody is so unique when it comes to their HRT.
Yeah.
What are they truly looking for when you're looking at aging? Like, for example, I feel pretty good. I want to continue feeling pretty good, and I wanted my brain back. You know, what is that, the Scarecrow in The Wizard of Oz? It's the Scarecrow. I wanted my brain back. So it was, that was for me, but I feel pretty good, so I want to continue feeling good. We have people that come in and they feel terrible, and we want to help them feel better and then maintain that. But I do think, when we were talking about, maybe it's more, I don't know, philosophy or something, but I got here fast. I can't believe I'm 52. I mean, I got here fast. I don't want it to stop. I don't want it to end. I don't want to grow old, but at the same time, I want to age gracefully. I don't mind the wrinkles. I don't mind the spots. They remind me of my mother. I inherited the spots from my mom. That's why I have them.
You're a little self-conscious about your spots.
I can be,
your
but your
spots are fine.
I'm getting more comfortable with them because it's okay. It's okay to age. We want to age. I don't want to look like a 25-year-old, but at the same time, I want to feel good. I want to, because we signed up for this 10K. So we signed up for a 10K in May. So May 19th.
You can tell them what it's called.
It's called Run Like a Girl. Yeah. So it's here in Bellingham. It's really cool. Anybody can do it. It's kind of like propping up for girls and athleticism and exercise. And you can bring your dogs. You can bring some people go in their stroller, with their kids in their stroller. So it's not like, and I think last time I did it, this was a couple of years ago, everybody got a number one because it's not really a race. But so we signed up for the 10K, and, the money goes to, good service there. But I want to do it.
And the park where they have is like right out our back door, so we sort of have to go anyways. And you can bring the animals, so
which we will
have to do that.
Bring our animals, which are scattered around here.
So that's even part of it, right? So running, maintaining how you feel, having the energy, both the brain energy, the mental energy, the physical energy. Because if you can maintain how you're able to perform, then that whole health span thing that we've been talking about is going to be maintained, then your lifespan is going to be extended for that much longer. I think if you, I decided like way back when I was in high school, I don't even know where this number came from, but I was going to live till I was 92.
All right.
Okay. I've made some decisions like that in my life. I don't know. So far, some of them have come true. So I'm going to live till I'm 92. So you have to live until you're 92 in a day.
Okay.
Okay.
That's the plan.
Right. Just kidding. But how do we arrive at whatever the number is? I would say most people would probably not care so much about the number as long as the time spent to get wherever they were was time well spent. Like they lived well during that time.
That is exactly what I was trying to say, and you said it so succinctly. It's so nice.
Oh, well, I just think that, if you're, dealing with some kind of a chronic condition for 30 years, I mean, that's not, you can't walk, you can't talk, you can't do this, you can't do that, you don't have your faculties, that's, your quality of life is severely diminished.
But even if, like we have patients that aren't aren't well. They have some chronic conditions, but if you can get them to feel a little bit better, that's a win.
Yeah. And I think that's in the short term, that's the part that the hormones can help with. Okay. Now, even the rhythmic dosing, and we talk a lot about rhythmic dosing. We both believe in it. We both use it ourselves. We use it with a lot of our patients. I find that the rhythmic dosing creates the best change in how they feel. Mm-hmm. Not in every case, like I said, 80-20, 90-10, whatever it is. Some don't respond well. We have to change it. That's totally fine. There's always the right dose for that person is the right dose for that person. But overall, the ones that are able to maintain how they feel or improve how they feel the most, at least on the female side, is really from that rhythmic dosing the most. Would you sort of agree with that?
Yeah, no, I would agree, because you think about, with aging, I think there's a new kind of thought process behind it. It's not about, because I do feel like the rhythmic dosing does keep your skin really nice and hydrated. Sure. It keeps a little more plumpness. It can help with the collagen just because there's, you're doing what what nature intended. So I do feel like physically, but really when you're thinking about aging, I don't think it's so much about, I want to, look like I'm 30 again. It's more about I want to feel like I can do what I want to do. Like when you were talking, I was remembering I love my dad. He's very nice, but he is a creature of comfort. He will take comfort well over activity. And I was just thinking about him, because sometimes he won't, if we're getting ready to go somewhere, he'll stand up, and while we're getting ready, he won't sit back down because it takes too much effort for him to get back up.
Yeah.
Which is like I was talking to another patient, every time I walk up the stairs at our house, I'm like, I'm so glad I can walk up the stairs and it feels good. My knees don't hurt. I got that strength. I get up there. I'm not winded. And I think about my dad, and one time he dropped something. I remember he looked at me because he wanted me to pick it up, because it would have been a little too much effort for him to bend over, because that's a lot of work for him. Now, granted, he is older. He has diabetes that he's working on. So he's got some chronic issues, but it does kind of make you sad a little bit, because it's just so easy to just sit back down and get back up for me. And I don't want anybody that can't do that. I want to work with them to be able to help them to be able to do that.
Sure. I listen to Dr. Peter Attia a lot. He's got a great podcast. He's all over YouTube. He's been on some other podcasts. I've heard him as a guest. And he used to be for the people that are not familiar with him, he used to be a oncology surgeon. And he decided to walk away from it. I think he probably got a little burnt out.
Cancer, oncology?
He was an oncology surgeon.
Wow. Mm-hmm. Hey, guys.
Sorry about that. And
always on guard. Security.
Yeah.
Call security.
So he walked away from a surgical practice and now focuses on longevity. And he talks all the time about strength. He used to be really big into diet. And over the last few years, he has kind of changed his tune a little bit. He's not so focus on dietary practice. Of course, make good decisions, not too much sugar, not too much alcohol, that kind of stuff. But he's really big, based on what the literature says, really big on strength and maintaining that muscle mass. I don't know what his practice is set up. I'd be very curious to know, but he puts people through like a little bit of a NFL combine workout to see where people are. Like literally taking weights and doing like what they call a farmer's carry, a 30-second hang from a bar, testing what your grip strength is, because these are the parameters that, now granted, your grip strength isn't going to determine how long you live necessarily, but how do you get a strong grip is by doing some type of strength-based activity.
So strength is aging.
In some ways, that's where the hormones come in, because if you have those hormones on board, testosterone for men, estrogen, progesterone for a woman, a little bit of testosterone for a woman, and now those muscles, because women, I think, are at a huge disadvantage, because you literally go into menopause, your hormones are gone, right? So I think that's why sometimes the decline for women, if you don't prepare for that, the decline for women can be a little bit more dramatic, because those hormones are not there anymore.
Well, that's interesting, because women are supposed to, at least I remember years ago, live longer than men.
Sure.
So maybe living longer isn't technically what we're talking about when you're talking about, like you said, aging.
Well, yeah, but we're talking, a couple of years. We're talking, 73 to 78, or whatever the longevity lifespan is, 70 something to 82. We're only talking a couple of years. Now, from when you and I were young, kids in the 70s and early 80s, I grew up around a lot of elderly people, and none of them could, they have to, 3 tries to get out of the chair, and they have to use their hands, and they at the time, a lot of them were in probably their 60s, where a lot of our patients are now, and a lot of our patients now, we have a population that does really well physically. We have a population that doesn't do so well physically. So that's sort of what we're talking about. How do you bridge that gap so you make that transition as smooth as possible, and you either avoid it altogether or push back all that age-related disease: diabetes, heart disease, Alzheimer's, and cancer. Those are the 4 things that we're all trying to avoid if we can.
Absolutely.
Yeah. So I don't know. He talks a lot about, like, that's why we're always pushing. You want to burn fat, you need to
Get strong.
You need to get strong, as opposed to worrying so much about weight or what the scale says. I think there's a transition there where you need to be more concerned about maintaining what you have. That's why I think even some of the GLP-1 medications, I think it's putting a woman at a little bit of a disadvantage, because now they're losing potentially a lot of muscle and bone density at a point in their life where it's going to be really hard for them to get those things back.
That is very true.
If ever. So, just sort of having that bigger conversation, where do the hormones play into that? Do they play into that? You and I both, firmly believe that they absolutely do, because we've been able to, like you said, you've known your patients now for some of them for close to 20 years. You've been able to see them, progress, some good, some not so good, over that roughly 2-decade period of time. That's like a research study, a long-term research study in real time.
That is true. Yeah. No. So I would say, the hormones. We're the hormone doctor, so of course we're going to advocate for the hormones.
Yeah.
But just from our experience, I do feel like that can play a huge role in helping good aging. So I think, like you said, it's not about, we're getting older, or who's living, I'm going to take hormones, I'm going to live 10, 15 years longer than I would normally.
Yeah.
Probably not, but the whole goal is I'll feel better. I'll have that quality of life for the next, for the remainder of my life.
Yeah, sure. I mean, are you going to make it to 120? I know there's a lot of people, trying to promote those kind of things. I don't think we're quite there yet. But I do think, at least for a woman anyways, I think that the hormones are a really big advantage that can, help extend both the, as Dr. Attia talks about, the health span. So how well you live on a daily basis, and at the same time, how long you're going to live for. You and I are focused on the health span part, right? That's what we walk all the time. We lift weights. We do those types of things. Of course, these animals need a lot of activity themselves. So I don't know what else to say about that. And you have any other ideas?
This is a great conversation.
Yeah, I think we're going to, kind of dive into it more, because we just barely touched the surface on the effects, the benefits of HRT. What we do know about the effects on the bones, the brain, the heart. Now, we said a little bit about the muscle. I think that's a very, very big deal. I tell every patient the number one factor for aging is, the medical term is what they call sarcopenia. So is it the hormones that maintain the muscle, or is it the activity that maintains the hormones that maintains the muscle? Like which one is the cart before the egg there? Like what are your thoughts about that?
I think it all works together.
Yeah.
I don't think you can tease it or compartmentalize it. It all works together.
Sure. I was expecting some kind of an answer there. You just cut me off.
Magic.
You just cut me off. Okay,
Sorry.
Great. Thanks for that. That's great. Okay, yeah, you're right. No, I know you're right. It does work all together, but we'll continue this one. If you have any comments, put them down below in the comment section there. We appreciate everyone paying attention and asking questions. That's always fun for us to discuss them on the podcast. Any last final notes, or
nope? This is great.
We just done.
Chop, chop.
Okay. All right. Until next time, I'm Dr. Maki.
I'm Dr. Valorie.
Take care. Bye-bye.